and good evening to everyone who is joining from all across the time zones. Thanks a lot for being here and taking your time on a difficult day. Thank you for being very much here for our healthcare webinar. So today the focus is on healthcare, focusing on Gen AI. We truly appreciate your time and hope you all having a fantastic day. So, as I said in the beginning, dynamic topic, which is reimagining healthcare, the role of technology in building a healthier tomorrow. It promises to be an engaging and insightful session, and we are thrilled to have such a great audience with us who are with us in the LinkedIn Live and in the live platform as well. Let me begin by introducing myself and AI CoreSpot as a platform to you. My name is Nitin Naveen, and I serve as the Vice President of Innovation and Strategy at AI CoreSpot. With nearly a couple of decades of experience working with different consulting firms on all the emerging technologies, I'm fortunate to have worked alongside global leaders, stakeholders from different geographies on some of their truly innovative projects. I'm also joined today by my couple of my colleagues, Arvind and Naveen. Arvind is there in front of you, and Naveen is there in the back end. A big round of applause to both of them and the whole team of AI CoreSpot for their dedication and the energy they have brought to organizing this event. A quick word about AI CoreSpot to everyone. It was founded as a platform 4 years ago. Our company serves as a knowledge hub for areas related to all the emerging technologies, which includes AI, Gen AI, machine learning, robotics, IoT, and a lot more. Through our webinars, we aim to keep you updated on the latest technological advancements across various tech sectors. We have a lot of freshly monthly themes, and we are growing momentum month on month. Our vision as a platform is to become the leading global AI-driven community, a place where professionals like yourself can grow together and share the success. We are committed to delivering industry-backed webinars, some in-person events, built upon credible insight from distinguished industry leaders, subject matter experts, all our trusted partners who have been with us throughout our journey. In addition to events, we curate some great content as well, which is across the blogs, podcasts, videos, newsletters, making it easy to stay informed about all the today's and upcoming fast evolving tech landscape. For today's session, I'll again revisit the topic in some different way, which is from insights to impact, smarter healthcare with the AI touch. Our speakers will deep dive into some of the key topics which you want to listen. I'm sure about that. I'll give you a glimpse of some of the topics which we are going to cover for today's webinar. It's about AI use cases, some concept about data and innovation, something about project and leadership strategies, what are the cybersecurity challenges, and future prospects and the emerging innovations which is in the horizon. We are confident that the insights, discussions, and the ideas you all will hear today will spark new thinking and drive the value out of whatever work which you are trying to do. Special thank to our community partners, VRAD and InfoVision, for their essential role in making this webinar a possible one. And of course, a heartfelt thank to all our attendees. Your presence is invaluable. Our platform is built to help you gain insights, connect with peers, turn inspiration into action. So if you leave with new ideas or strong connections, we'll consider it a very great job from our side. Let me introduce our esteemed panel of speakers for today. We have Inderpal Kohli, who is the healthcare CIO. Then we have Brian Baker, who is AVP of Software Engineering at VRAD. And then we have Adam Rizin, who is Director, Healthcare and Life Sciences at InfoVision and serving as today's moderator as well. Just a brief disclaimer as we do it on all the webinars so that it becomes necessary from a legal perspective. The views shared by all the speakers who are today are their personal opinions and not necessarily represent the perspective of their respective organizations. With that said, thank you again for being here, and let's get started now. I'll hand it over to Adam to kick off this exciting panel discussion. Over to you, Adam.
Thank you, Nitin, and thank you everyone for joining our discussion today on the role in technology and how it's being adopted for a healthier tomorrow. As we all know, over the years, there have been many innovations. In particular, AI has been very concerning for some, but very real in healthcare. Being adopted to support, and I've got a little list here, but improve simple things like scheduling, medical adherence, readmissions, disease predictions, gets into drug discovery, personalized treatment plans, anomaly detection, we're going to talk a little bit about today. Mental health in particular tremendously benefited from telemedicine, and real-time wearables are creating faster, smarter, and more personalized experiences. Some of the most compelling, widely adopted use cases are designed to assist, support clinicians, and enhance their workflows, and ultimately help clinician burnout. So just last week, the White House released plans to create a patient-centric healthcare ecosystem. Or 2 weeks ago now, sorry. And although many of us are still unpacking the details, it really is a collaboration between 60 plus healthcare organizations, including Amazon, Apple, Google, OpenAI, United Health, Epic's on there. CVS is committed $20 billion to innovation. In short, I guess technology is here in healthcare and it's expected to advance further and further. And we're joined today by two of our industry leaders who are driving the change and advancement and actively shaping the use of technology in healthcare. So with that, I want to just introduce them, or let them introduce themselves rather, and then we'll get started. I do have a few questions that I've prepared, but we are going to have a lot of room for Q&A. So please type your questions in the chat. If we don't get to them as we go, we'll get to them at the end. So please, Inder, if you could start and introduce yourself.
Thank you, Adam. And thank you, Nitin, for the overall introduction. And I'm really happy to be part of this discussion today. Exciting topic ahead. So as a background, I am a healthcare technology leader with over 25 years in leading, managing technology operations, innovation, strategy, digital transformation across complex healthcare systems. I mean, I'm privileged to have really an experience across the whole spectrum with academic medical center, teaching hospitals and community hospitals, and even ambulatory physician practices. So that has really shaped my experience and opinion about where technology is a differentiator. Within technology, I have over a decade working with Epic, one of the leading EMR solutions, across large complex health systems, implementing, optimizing, and more recently embedding AI-driven modules for both clinical efficiency and patient engagement. Beyond Epic, I have significant experience in modernizing infrastructure, cloud strategy, cloud application rationalization, cybersecurity, and really enabling transformative cloud-based solutions like an imaging or other such. I would say throughout my career, I've been at the intersection of strategy, technology, execution, and innovation, leading these transformation, not just as a CIO, but as a strategic partner, as you can say, like an internal consultant. And that really has helped me build scalable solutions, extend platforms across all care settings, and really establish a service models which has delivered measurable outcomes. And I'm happy to share my experiences and my insights as we progress through this webinar.
Thank you, Inder. Brian?
Yeah, well, thank you, Adam, Inder, Nathan. You guys have all done a great job here introducing yourselves and what we're about. I'm Brian Baker. I am the AVP of software engineering here at VRAD. I've been at VRAD for, about 15 years now, and the last 10 really focused on a lot of what we're going to talk about today, artificial intelligence and how to take some of these emerging technologies and actually make them work in the existing technology stack, and in the existing clinical practice, right? So super excited to talk about that. A little bit about our background, my background. VRAD is a large teleradiology company. We serve something like 2,000 facilities across the United States. Have connections to something like 150,000 unique imaging devices. We'll read somewhere around 7 million studies and about 1 billion images. So just a ton of really fun numbers, and I'm excited to answer Adam's questions or your guys' questions, and dig into how we make some of the cool stuff actually work in the real world here.
Okay, thanks, Brian. A billion. Did you hear that? A billion images. I can't wait to get into those details. Okay, so I guess let's get started. We'll dive right in. Inder, Brian, you've implemented technologies, AI solutions to build a healthier tomorrow. Can you tell us, maybe introduce a use case or two that you're, most sort of proud of or went extremely well, and maybe why did you choose those versus others, and how did you get to a sort of the initiation phase? So Inder, if you want to start with you.
Sure, I'm happy to
It's
start.
a big question, but
Absolutely. So I would say, right, in my role all across, the institutions, I had an opportunity to lead several initiatives, and recently more with AI embedded, not just as a standalone shiny tool. I'll put it as part of like an integrated outcome-driven strategy. And the reason for that is because it is not really about aligning solution alone. It's aligning solution with the organization strategy so we can deliver the outcomes. Otherwise, it become, just a shiny tool, which is what we're trying to avoid. So I'll bring a few examples of it where, we had an opportunity to bring in solutions for either clinical efficiency, patient engagement, or some of the other efficiency functions. So the most one which comes to my mind is an AI-powered clinical documentation support within Epic to assist providers in real time. This is the real-time documentation as they are having a conversation with a patient rather than typing away while seeing a patient. It improved compliance, freed up really more face-to-face time with the patient, improved compliance in terms of timely documentation, of course, assist in coding and a structured note. Similarly, we implemented a AI-based predictive analytics tool for high-risk patients for either readmission or proactively engaging care teams. Again, these are measurable patient safety as well as the quality improvements and reduce, of course, avoidable readmission. So you asked the question, why did we choose this versus others? And I think the answer to that is each of these were not just projects on their own. They were part of what we are trying to implement as part of our overall transformation strategy. They were aligned with what organization wanted to deliver, what the needs of the organization were for both its clinician population as well as for the patient population. And that is where the adoption becomes a reality. Otherwise, we can implement tools and we really don't get adopted. And if I have a few more seconds, I may want to bring up something which is also pretty cool, is that, we implemented an AI ML-based medical device security solution, really for anomaly detection of a network for connected devices, medical devices, and essentially all IoT devices. Now, the reason we selected this solution over other, as I mentioned earlier, in this case, is a clear benefit which we are trying to achieve here, keeping the organization safe, trying to address the vulnerabilities in really one of the most overlooked portion of our cybersecurity, so to say, framework, medical devices, because we don't have much control over it. So now traditional technologies were too cumbersome and too much for us to input in terms of effort and resources with not a defined outcome versus an AI ML-based tool, which is proactively scanning my network, matching the patterns, matching against all existing vulnerabilities, published or unpublished, and really helping us prioritize the remediation effort. So two different, so to say, user groups here, one clinician patients, the other is really my internal resources whose primary job is to keep an organization safe. But we all know, there's too much to do and too few resources. So if a tool can help us prioritize and address the most vulnerable situations, I think that warrants the implementation of it, and that's what we went with.
Okay, just a little follow up on that. And recently in the news, right? Epic is they've got their own ambient AI now. They've developed it internally. It's coming out. It's supposedly, there's posts about putting people out of business, companies out of business. I know it's fresh and new, but any thoughts on, you've implemented it? It's there. It's live. What does that do for the world right now?
So I think I would start by saying we are at the very initial stages of these deployments, which also means that there's a plenty of ground to be covered. So, in other words, there could be plenty of opportunity for everyone. So I don't think the vendors who are already in this market few years ahead need to worry so much about losing a business share, because we talk a lot about ambient AI documentation, but in terms of absolute percentages, probably maybe 15% of the organizations have deployed it, right, to any scale. So there is plenty of ground to cover. Now, it's both ways, right? Today, so Epic integrated solution, always a great idea. I have implemented the texting solution, replacing external vendors. It works very well for not only our development team, but for our user population. And the whole integrated framework enables the utilization of a tool and the value we get out of it much more. So with Epic integrated ambient solution, I think it will have that factor of added value, integrated single database, part of the same framework. Where it could be challenging is announcement just came out 2 days ago. So don't know at UGM, probably they'll declare more. What functionality are they bringing up live right now? Because the other vendors are probably 3-4 years ahead in terms of all the functionality. And yes, is Epic matching them today, or is there a roadmap to match them in 2-3 years? Either way, it works for health systems. Even if I have deployed a solution, if 2-3 years down the line, if there is a better option with Epic, we all can consider. If there's not a better option, we can continue on a roadmap. I think so. The details need to be clear around to what functionality are they bringing in, or is it a long roadmap of 2-year time frame? Then it's a different conversation for the health systems who are live on it. But again, I will end by saying there's plenty of ground to be covered. So I don't know really if that is going to make a big difference. Yeah, there will be a difference in terms of organizations looking to go live, whether I should go for a third party or an Epic. But generally, there's room for everyone.
So I guess going back to part of your answer there was patient-centric ecosystem. Sometimes in one place is easier, but I'm going to segue to Brian here beautifully in that you mentioned 2,000 facilities. Well, that's probably 2,000 or more interfaces, and his interfaces are working. There, 150,000 images and devices they're connected to. So there's already in your world that the patient-centric, it's all working and integrated. So can you, I guess, segue over to you and tell us a little bit about sort of some of your innovations and
I think Inder brought up a couple of really excellent salient points, which is you really got to find solutions that help your patients and that or help your doctors, your users, that they'll adopt. And it's harder than it sounds. And Inder made it sound easy, but it really can be difficult. The other thing I'll just echo real quick before I jump into some of what we've been doing is. Radiology AI really started kind of getting buzz maybe in like 2015. And the very first wave of buzz, as is expected, is, oh no, we don't need radiologists anymore. AI will do it all. We're 10 years later, and AI is not doing it all. I apologize. I don't know the attribution to this quote, but a common someone said it once, and we've all been repeating it. Is that while AI probably won't replace radiologists in the near future, radiologists who use AI do stand a better chance of succeeding, where radiologists that don't can fall behind. So just echoing like there's a lot of hype and concern, but it really is a challenge to find the right exact use cases. With that in mind, VRAD both partners with AI companies and builds their own models. So we have the chance to have to answer that question in multiple layers. What's available out in the market, and what do we actually go build? And VRAD started out, what we really wanted to do was help our patients. And so as part of that, how do you get value out of models very quickly? Meaning how do you test them, validate them, make sure that they're safe for your patients, et cetera, which is all a very large task. And our first use case became prioritization. VRAD reads a little bit differently than other practices in that we read kind of top down. We tell our radiologists what to read versus them picking off of off of a work list. So we know, what order the cases are going to be in. So we began building models that could detect things like intracranial hemorrhage, aortic dissection, other critical care acute use cases. And what's exciting about those is if we can find an ICH and bump it up on the work list, we not only save lives, but also the quality of life. So there's a common saying in radiology, well, in medicine, time is brain with intracranial hemorrhages, and what that means is 2, 3, 4, 5 minutes can matter. And so our ability to take an ICH, discover it with AI, bump it a little bit higher on the priority list, it may only save 3 to 5 minutes, but that 3 to 5 minutes for that patient has a huge impact. It can be the difference of a very normal quality of life versus a much worse outcome. The other use cases we advance, sort of, if you will, in our pipeline is quality, and this has been sort of our obsession in the last 7 years. It took us on a journey that we weren't expecting when we began it, but you have conditions that radiologists do not detect as well as other conditions. One of our favorites is SMA occlusion. So SMA, superior mesenteric artery, is a artery in your abdomen essentially, and it provides blood towards your gut. And if it gets occluded, your intestines start basically having no blood to them, and then that's not great. We won't get into gory details, but radiologists in the literature catch SMA occlusion about 89 to 100% of the time. And the reason is it's not actually that hard to see, but we know that realistically radiologists see it about 55% of the time, and they miss it about 45% of the time. We know that because we have AI running that automatically detects any miss. So it'll go, hey, the RAD said it wasn't there, we said it is there, and it immediately puts it on a different radiologist list to make sure we're not biasing anybody. And that radiologist makes an adjudication and says, hey, the AI is right here, calls up the first RAD, and has an immediate teaching lesson with them. And oftentimes we're short enough in that cycle that we can also help the patient right away. And what's crazy about that, like SMAO, is it's not because it's hard to miss, and so it's very hard to study. Because if you build a study that says, hey, look for SMA, they will find it every single time. It's these rare, more acute conditions that lots of things are going on. Maybe it was a trauma, maybe there's just other pathologies happening, and the radiologist is just misses it. Doesn't think to look there is what happens, and this particular pathology is prone to that, and so we're able to really quickly reteach our radiologists, and it's had an immediate impact, not immediate I guess, but an impact over the course of a couple of years. Radiologists learn, right? We're giving them feedback, they're human, they learn to essentially check the SMA for an occlusion. So really a partnership between AI and humans that is evolving over the last 10 years, and I'm excited to see it keep evolving as well.
Cool. And then data, right, is sort of the next question. And Brian, maybe you're on that topic, but your data your images, the quality of them. I know they have the headers for the PACS images, all of the header. They have to have this thing in different formats, and if it's not, then you can't read it. And data in, data, right? Learning, relearning, garbage in, garbage out is a big saying. So in the AI world, how do you, I guess, with your diverse data sets, what the most pressing challenges, what are they? How do you use this data ethically, responsibly, free from bias? And I just want to get into that bigger data question. So maybe you can kick us off here, and then Inder, I know you've got a vast array of data within a CIO level, so we can get over there too. Brian?
Yeah, a lot to unpack. I'll start with just VRAD has our own pack, so we developed our own pixel archival communication system. So the images coming in ingest into our own packs, and we're connected to, like I said, over 150,000 different imaging devices. I like to tell people really nothing to do with AI, just technology, right? like if someone sends it in the country, we've probably seen it. When we first rolled out our software, boy, 18, 19 years ago, it was common to be like, what is this? What is happening? Like this error, what is going on? Over the years, I think maybe one or two of those crop up now, still. But just the amount of, yes, it's standard. DICOM is standard. 807 is standard. Whatever standard you want to throw out there. But we all know, standard is standard isn't standard isn't standard. So it's just a real challenge to collate all that data and try and figure out, yeah, how do you get models to learn and not accidentally train, very specific and very generalized. And we're fortunate in that, we just naturally have a very diverse data set, and that has been very, very helpful. The other kind of, part of the question is how do you how do you use that data ethically? And VRAD, another one of our obsessions is asking that question. And we built a very specific de-identification process. We couldn't find a tool. There are tools on the market, but we just couldn't find one that met our exact needs at our scale. And so we built a de-identification system that really is geared towards, making sure that this data is de-identified and that there's no way, as engineers, we spend a lot of time thinking about things that probably aren't probable anyways. But there's no way, even in those improbable scenarios, that identifiable information slips through. So we take that really seriously, and I think some people come in and look at it and they're like, you guys are in corner cases that are just never going to happen. But it matters to us, and we spend a lot of time thinking about it.
Cool. Okay, Inder, overview, I guess.
So mine is some of it same perspective as Brian, but more broader too, because I feel we are swimming a lot of data in healthcare and all across the spectrum. Structured EHR data is kind of the core of what we have, but then it's substantiated, augmented with tons of other third-party data sources. Imaging packs is definitely one of the second largest data source beyond the EMR. And then now there's really a lot of telemetry data pouring in, patient wearable data. So I think that the key for us is, and the real question is, how do we ensure that it's clean, good data without bias, so that the models could be trained? So I'll put it in two contexts. The models and the AI LLM training has become more like in our lexicon over the last 3-4 years. But the goal of having a clean, dependable data has been there from the very beginning. I mean, I started my data journey back in Columbia, but even HSS, where we launched the first data warehouse. One of the challenge we had about was around setting up the right data governance, because that's the number one thing we need to ensure. Clear ownership, standardized definitions. Believe me, a simple thing like a length of stay has 3 different definitions in average hospital. To come to terms with, we can have more than one, but what are the parameters around it? It takes a lot of discussion and participation. And then, once you have this data governance, data quality standards, so to say, data stewards identified, then behind the scene, technically, we can do some data quality checks. And, so that any decisions that are being made based on that data are based on a valid data. The data which passed our quality check, the data which passed our definitions, data which has been standardized. So that is for daily operations of healthcare, but also for research, also for predictive analytics side of things, and also for the business operations or the growth decisions and all. So that's the one piece of it. Now data is taking a different context, that your data is probably being used to train the models, so who can go and help you. We are largely vendor-driven space in healthcare space, largely vendor-driven market, vendor product. So that's the question I pose to them. What is your level of due diligence? My data is a source of truth for me. Is it 100% clean? No, but I'm working on it day in, day out. That is my source of truth, for better or worse. It's not a made up data. That's what we base our treatment decision. That's what we base our operational decision. Is your algorithm matching this data with other sources which are equally reliable? So that's one way we want to ensure. We want to have those questions, structured questions. Our compliance, our legal departments help with those things just to get the validation. Now, eventually the time comes when these models are being trained on our data, right? And that's time, the number one thing, of course, is the data security, and that's not a de-identified data for most cases. For certain databases, there's a de-identified data, but for us, the value of an AI solution is that it's able to identify and offer us a workflow solution, an actionable item based on an identified patient or identified clinician. So that challenge remains on a provider side. On a vendor side or on an AI, I had experience with radiology where we de-identified data and the models were trained, and that makes perfect sense. But when it gets applied in my environment, it is all identifiable data. That's where the action happens. So that's how I've been proceeding with it. But I think to go back to the basic definitions, which have been there from the very beginning of data strategy, governance, definitions, data stewardship, a single source of truth. That's one. And then you kind of hold your vendor partners, the solution partners, accountable to the same level of standards.
Right. And I guess that the clinical involvement, some of the clinical notes have a limit of 100 characters. Some have 70 characters. The new Epic it has some limits supposedly that I'm hearing about. So do you do it in 2 notes, and do you have to bring in both of those notes and equate it to the one from the other system? And that management, ultimately, the clinician, the buy-in, it sounds like having a governance in process to say this is equal to this is equal to this.
And then we have worked a lot on recording as much discrete elements as possible, as much structured node as possible, but it depends on organization to organization. Some have node standardization across physicians, some don't. I have worked in both kind of organization. Even with the node standardization, every physician have their own flavor, and rightfully so. Maybe every specialty has its own flavor. So that's what I would call the data mining, which was a big challenge 7-8 years ago with unstructured data and nodes and all. Yeah, data lakes gave us the promise. That's where I think the AI solutions have an edge, because they can quickly mine that unstructured data and draw conclusions, or bring us something to work with. Now that's where also is the higher risk item, because how are we validating it? It's easier to validate my structured data against the parameters I've decided. So I think it's what do you call it? It's a boom or a bust both thing, right? There's definitely an advantage of a quant computing model sifting through millions of unstructured nodes and drawing conclusions. But do we have ability to validate it? Humanly not. And I don't know if I have answer to that question, but that's definitely a valid question. How do we validate what the model brought to us?
Okay. And I guess it kind of segues to my next question on sort of balance of innovation and patient trust. In gaining adoption of deploying AI, scary AI, right? How do I trust that it's being used responsibly? We've touched on the data side of it, but what project leadership strategies, I know you've touched a little bit about on it, but would you say are most important to help you cross the finish line, to get to that production, to ultimately sort of prove the ROI that you were going for? Is there, one particular, scenario or two that you can sort of highlight for us to help you get to that finish line?
So I think every decision around these starts with bringing together a core group. What you can call it a governance, you can call it a sponsors, champions, either one, which really includes clinicians, compliance, operations in the design phase. So I never worked in an organization where I can just bring shiny tool and then think about adoption. I work other way around. Before we bring anything in, do we have a consensus? And then of course we start small with proof of concept, with a clear success metrics that really matters to the care team, to the leadership, to the CFO, to all of us, right? So is the solution bringing the value? Is solution being adopted? Is the solution bringing the ROI? Whether it's a direct targeted dollar ROI or a value ROI or a regulatory compliance ROI, any of that is fine as long as we are measuring it. And then I prepared my leadership for one thing. I said we are in a different ecosystem where not every solution is going to work, but one thing we can be prepared for is that we may fail quickly and move on. So in 3, 4, 6 months, we will measure it. We will realize it, whether it's meeting our agreed upon metrics, agreed upon values being generated. If not, then we should have a courage to leave it behind and move on to the next solution. Easier said than done, but at least there is that filter there in terms of every solution we launch. Now, my bigger challenge there is now that we run this proof of concept, 100 physicians, we see the ROI. Is it scaling up to the enterprise? And that is yet to be seen, because now we're scaling some of those solutions now, and we'll monitor the metrics. I have a feeling that the sample size may not be, or the enterprise size may not be same as sample size. But so we have some thresholds there. At least we need to meet that. That's one way. The other, of course, is, do we want to be left behind? Because whether the technology or adoption will improve over time, no doubt about it. 10 years ago, 15 years ago, clinicians were worried about counting clicks on EMR. Today, no one questions that. EMR is the standard operating system in the organization. Few years later, adoption will increase. Technology, of course, is increasing the leaps and bounds. So do you want to be left behind, or do you want to be in it and hit the ground running when it scales up to that level? I want to be in the latter, don't want to be left behind. But that's not my decision alone, right? That's where I have to bring my leadership, the executive decision-making body, and the board together on it, that yes, these are the metrics. Maybe we're not tracking on all of them, but here's the reason we stay in it, or here's the reason we get out of it.
Okay. Sounds like logical. Proceed with caution, do it in a smart way to expand and grow and go beyond. So, okay, Brian, I know you're a little bit different in that you're doing vendor and approvals, and sort of people are bringing you solutions, and you're evaluating them essentially. So can you tell us a little bit about your sort of process? How do you get from sort of beginning, middle, particularly the end and the adoption?
This is one of the most challenging parts of this, right? People in general, outside of healthcare space, I think this is true too, are both excited and scared of AI, and it has a lot of hype, kind of cloudiness to it, and so I think a lot of our time as leaders gets spent demystifying what this stuff really is. And that's, if I had to give someone advice to like how to help do this, it's just conversation after conversation, explaining the details, because people just want to understand, what does this really mean, and they have a picture in their head that is scary and exciting, or both, and helping them understand like what actually happens behind the scenes and what we really mean when we say implement, right? It as business leaders, it ties back to what Inder was talking about, earlier in the conversation, of finding the right solution to the right problem, and finding ROI, et cetera. But on an individual basis, how do you get that out the door? And people that, person 1, 2, 3 doesn't necessarily care about, the business's ROI. They want, like, how does this impact me? What does this mean? And so it just, time and conversation is huge there for me. Some of our examples, one of them is really, radiologist QA. I don't know how, most people feel outside of radiology, but radiologists don't like to be told when they're wrong, because it means they were wrong, just like the rest of us don't enjoy being told when we're wrong. And a lot of radiologists, is kind of a funny, saying, we'll talk about it. A lot of radiologists will come to VRAD and they haven't had any mistakes in their career ever, because no one has looked. And that's okay. Like that's just where a lot of radiology practices are. But then to get told, hey, you missed an epidural lesion, is a shocking experience, and we try and make that gentle as possible, but also it's a training experience. So epidural lesion is a great example. It's essentially fluid in your spine. We can detect it on CT. Many radiologists are actually taught in school and in the residencies that you cannot detect epidural lesion in CT. That it's not possible. And so when we detect it with an AI, and then we explain to them that it is possible to see an epidural lesion on CT, the first reaction is always going to be like, wait, what? I did something wrong? But also like, hey, we all want to get better. Most people got into medicine to help people, and we all want to get better at helping people. And so just walking them through that process gently and going, no, you can. And then because we have a model detecting it, here are 15 cases you can go look at to help you learn how to spot epidural lesion. I think for my team, it's like the actual engineering team, it's kind of funny because we're out there and we're going, hey, our model is awesome because it can detect this many misses. Meanwhile, the radiologists are all out there getting better, and our model detects fewer misses over time. And so we look worse. We're happy to look worse, by the way, but it's just kind of a happy side effect. So.
Oh, that's great. That's great. So I have some questions here relevant to that, but I'll save them for the Q&A period in a minute here. Just cybersecurity, challenges in healthcare face as they adopt cloud AI-based platforms. Data coming in. How does cybersecurity come into play, and how are you, addressing and resolving for the cybersecurity challenges? Inder, can you start on this one?
The antidote has to be AI. That was my go-in position on this. Now you are in a different world with an AI-based attack. The vulnerabilities could be exploited much quicker than they used to be. I mean, my favorite example to bring is 0 day. We all have solved 0 days, within few hours to often within a day. And now it takes a different flavor. Is 0 day, by the time my team even gets their hands on it, has been exploited by an agent. Very much a possibility. So and without this, I mean, the AI has become more household name now over the last 2 years or so, but that's more generative AI, conversational AI. As Brian rightfully mentioned, we've been using AI for a very long time. Radiology was also my first use case, then was pathology. And then, cybersecurity and infrastructure, I've been using AI-based tools there for a very long time. I implemented an AI-based SIM solution rather than a traditional SIM, which is, monitoring the logs and someone is making a decision based on each monitoring, rather than a proactive solution, which maps us against 16 different sources of, external vulnerability, CVEs and all that. And then also looks at my environment and tells me, these are the 5 vulnerabilities you need to prioritize. I think it's all about better efficient utilization of my resources, but more importantly, being proactive. All of our endpoint detection and response devices, CrowdStrike and all, have AI component built into it. You're not really downloading definitions anymore and being in the reactive environment. But the threat is real. The bigger threats now are with the new world, where a lot of data is being part of language models. A lot of data is transacting between various models and a cloud-based solution. The threat is real about, are we securing our PHI enough? I think we've gotten to a point in healthcare that with any time I have to initiate a data exchange, I go through the basic third-party assessment. It's more than basic, it's comprehensive. SOC 2 certification, data encryption, storage, REST, all of those things. They still hold true. Even in the AI world, those checks and balances hold true, because you need to be diligent about launching or sharing your data with a third party and assuming that they are following the same standards as we are. Now, are we following all the standards? To the best of our knowledge, we are. because we have the number one pledge we have is to secure patient data within our four walls, within our perimeter, and also when that data is shared externally. Oftentimes, it's the humans who are the weakest link, and so the phishing emails no longer come with all those typos and grammatical errors that are easy to detect. They are slick as anything. So the extensive training for the organization. Number one piece of any cybersecurity program should be awareness in the organization, because that's where the vulnerability will occur. Because we all have done a great job in securing our perimeters, our endpoints, even to, I would say, data exchanges. So and then the zero trust approach, it's going to become a requirement, in this framework, because we are, I think and I can tell you from a provider organization perspective, it's like a huge star diagram of how many places we exchange data with. To get a good handle of it is absolutely a must thing for an organization. But I think the better model will be then you can go with a zero trust organization. So then if in case we missed out on something, at least the vulnerability is contained. There's no lateral movement. All of those are part of my design, and I think that should be part of our design, and will continue to evolve. But I will end by saying that the antidote has to be the same as the cause, which is something more than human intervention.
So one of the things, zero trust, I was going to just specifically ask on that. So newer term, right? Zero trust, what does it mean exactly? And maybe, I don't know if Brian, I can sort of segue to you. You've got 2,000 interfaces. You've got to have some kind of trust associated. So maybe you can give us just a quick, what is zero trust, and how are you implementing security over at BRAD?
Yeah, honestly, you could take Inder and plop him in our security meeting, and he would fit. Like we would have the exact same conversation. He would fit right in. Everything he talked about is really just critical. In terms of zero trust, I think many of us have aimed for that for years, kind of a new term, but for me, it's just what the other is, I always forget the acronyms, but the least amount of permissions, right? Like how do we lock things? We don't like to use the term lock because we don't want to lock our users out of things, but from a network segmentation, from a connections, how do we make sure that this data can only get to this point, and it can't get to this point and this point? And I honestly, Inder did just such a great job. I don't have much value to add. I will say the other thing that we think about from an organizational standpoint is, look, these AI tools are really cool, and we have people out there like my department of software engineering. We have people out there going, "Hey, look what I built," and we want to encourage that, but we also want to figure out how to govern that in a way that we just don't have, everyone building their own little mini software applications that do this and that don't have zero trust because they're not part of, the overall IT governance. And so I think from that kind of corporate perspective, the biggest challenge that we face that we haven't solved, right? That we're like, what's the answer to this? Is that balance between enabling people in the company to use these really cool AI tools and making sure that they follow our governance processes like zero trust, like least permissions. It's a real challenge.
Okay, so with that, I'm going to jump to questions from the audience. We've got a few of them here. I'm going to read a couple of them. I'm going to save one for the last one because it's sort of the future question that I wanted to state. But what is one of the emerging technologies that, in your view, is still underestimated but will fundamentally change healthcare in the next decade, healthcare delivery? I don't know who wants to jump in on that, but emerging technology, still underestimated, will change healthcare.
I think and I often talk about it. What we are doing is with digital and AI transformation is essentially addressing some of the low risk functions of the healthcare. We are, we're looking at clinician efficiency, patient engagement, internal back office efficiency functions, automations, those kind of things. The real value in my mind will come in few years when at the point of care, an AI tool is able to make a decision for the clinician. Now, and I'll say this with a grain of salt, a tool is not going to make a decision, at least not in the US, not under FDA regulations, but maybe it will start in other countries first. But at least you get to the point where there is an enough, process which has been validated, and more importantly, enough faith that has been given to a solution or a tool. We all are used to this alert, best practice advisory alerts, but this is more than that. This is really targeted to a patient. So that's one thing. And then I often talk about the real nirvana, the technology which will change the healthcare is personalized medicine. That's probably maybe 5-10 years away, if that. And that is where we are not just basing the treatments based on the general population categories, demographics, but really you as an individual. Today, we don't have that capability. Today, we don't even have that mining and a data and a profile of a patient. But with advanced computing, with quant, and with all the algorithms, that is an achievable stage. Not easy to achieve, but that will be really a nirvana where we get to the point of personalized medicine of Brian needs this solution and Inder needs this medicine and this treatment, even though they have the same condition. So I think that will be a game changer here. That's what I can think of right now.
Brian, do you want to add to that, or?
I like to, when people ask me this question, I like to think about just how quickly we've come to this moment and remember that. I think it was 2017, Google published What's So Great About Attention and introduced transformers. It wasn't until ChatGPT really kind of blew up on everyone, all of us as a society. For me, that like 2023-ish, where we started taking generative seriously. If you pause, like right now, just went, okay, no one make any more AI advancements. It would take us 5 to 10 years to unlock the existing potential out there. It's crazy, and it's an exciting time, and to like. So when someone asks me emerging technology, I'm like, it's whatever is after Transformers, right? Whatever is after what sort of enabled this latest round. But at the same time, like we don't even need that. Like we have so much to do based on what we have. And to add to Inder's point too, I think getting into more specific, more personalized medicine is there's a sort of feedback loop, and that AI will allow us to better categorize, better help humans figure out how to structure things. Like it will force us into that mode. And when that happens, there's like this other feedback loop that the AI gets better, because now you're taking the results of the human plus AI and you're plugging it back into training models, right? To improving models, and it makes the models that much better. To the point of like we're going to add data by the sheer amount of tools that come out based on AI that enable you to be more structured in a shorter amount of time. I think all of us wish, Inder talked about, we deal with this all the time in radiology. So every practice has their own little flavor, every department has their own little flavor, every person has their own little flavor. And there's a lot of value in that. And I don't mean to take that away from people, but there's also value in being able to figure out how to structure all of that so we can make conclusions out of it at that scale. And AI is going to help bridge that gap. And I think it's both nerve-wracking from a people like their personality, they like their individualism, to how do you structure that back together.
Okay, just going to another question. I know you've sort of answered this already, Brian, in the radiology world, but how do we ensure that frontline healthcare workers feel empowered rather than replaced when new technologies are introduced? I know you talked about radiologist training, and they actually benefit greatly from from this. So Inder, if you want to just touch on that a little bit, or Brian, if you want to add to your answer, feel free.
In the quote Brian used, I also read that a little while ago, and I've been using it too, that AI is not going to replace physicians, but physicians who utilize AI will benefit from it and will see a better outcomes overall. So I don't see a frontline healthcare worker being replaced by AI. At least I don't, because that's a skill. And AI is great in a lot of things, but that's a skill where it still needs human touch. I see that AI will be aiding and making them more efficient and helping them with their times and prioritization and keeping patients more engaged in their care. Definitely. Now, there are a lot of other use cases where, yeah, there is this worry about, the agentic agents taking over work, which probably is part of a normal evolution of technology evolution. In if you go back 100 years or 200 years, right? Everything has taken on more work. Humans are probably not doing that anymore as much, but that doesn't change the trajectory. Maybe they go on to more valuable tasks. But I am less worried about clinician being replaced. I'm less worried about radiology. Yeah, they can read the X-rays, radiology, but as a patient, all of us, think about all of us, we want our doctor to tell us, not a computer tool. Yeah, for second opinion and third opinions, yeah, Google and AI is all great. But do we act on it? I don't think so. I am not there. Maybe I'm old-fashioned. Maybe the newer generations will do it. But I think there are certain triage functions which can be better for patients. Today, our system doesn't have enough capacity to manage all inflow. So maybe there is certain level of triage eventually with the time that appropriate direction is given to a patient as a first step, as an information only, but not replacing.
Okay. Cool. Okay, so we have a couple of minutes left. Just sort of the final question, and it's in the chat as well, is healthcare without barriers. The future, if you will. What does the future look like? I know, Inder, you've hinted towards it, but that was with current technologies. What's 10 years, 20 years look like in healthcare for us? Brian, you want to start on this one, or?
Sure. We talked about transformers, generative. I usually use the term generative AI. There's so many different terms. What I like to explain to people is when mine is around 2015 for radiology. When CNN's, kind of classic AI, if you will, at this point, first came out, it was crazy what you could do with a CNN. So much faster and easier and better than what you could do with traditional programming, like writing an algorithm. And that moment for radiology started around 2023. It started earlier for some other some other parts of the industry, but of now transformer generative AI can do what it used to take CNNs a long time to do, right? And so there's the step function that we're just starting to unlock right now in my field. And so I think the future is more pathologies, more like a step function of being able to aid the radiologist, essentially, is what's around the corner. And to Inder's point of, I think we all want a physician reading, but at the same time, sorry, not reading, but like practicing medicine. At the same time, our hope is the things that waste the physician's time, that they really don't need to spend time on, the easy questions, if you will, we can take that away and let them focus on the hard problems, because there are vast opportunities that we could be doing better in medicine, but they take time and energy. And so figuring out how to reallocate that time and energy to those bigger problems helps all of us. And so I think that's the future, is medicine, again, to get to Inder's point of personalized medicine, it continues down that track of letting doctors focus on the hard stuff.
If I may add, I don't think I have the brain power to predict technology, because I'm not going to move that fast as the technology is moving. But I think directionally what I see is the future is more going to be on personalization, precision, and more importantly, proactive. And I see whatever technology comes, because I have really no crystal ball on technology, I think that's where we are moving. And Brian touched on the same point, right? We're trying to remove friction from the environment. We're trying to remove non-value add work from clinicians' workflow. We are also guilty of adding, like EMRs added a lot of documentation and other work, which took them away from patient care. Now we're trying to reverse that in a way. And that's the right thing to do, because what they should be doing, what they are doing best is the human touch, the healing, the empathy, the judgment, which no network can do, no technology can do. And if we remove the friction and we are more on a proactive trajectory, more on personalization trajectory, I think that would be a good future to be part of.
Okay. And me, I'm worried personally about the digital twin thing. What if I eat this and exercise? What if I don't? And the predictions associated. So thanks, guys. I appreciate your time. I know we're out of time here. Nitin, I'm going to hand it over to you to close us out. So thank you very much.
Thank you, Adam. I know we have a lot of things to say in this call, and when we discuss about the technology driving any industry, that's how the discussion is. I think an hour is very less time when we take the discussion, and we have so many questions I'm sure audience must be having. But in case anybody want to ask question, they can write it back to us, and we'll try to get it answered with expert sort of panels who have come to for today's webinar. So thank you, Adam, for expertly moderating today's session. And we deeply appreciate the insights. That means the invaluable insights shared by all our eminent speakers, Inder and Brian. Your willingness to collaborate and give the knowledge to the large audience and who's listening to you through different mediums, I'm sure it has greatly enriched our event as well. For those who missed the live webinar or wish to revisit the discussion, the recording will be available soon on our company's YouTube channel. The event, as I said, was broadcasted live on LinkedIn Live as well for greater accessibility. Looking ahead, we are excited to explore the latest technological innovations, which is not for 10 years, 15 years, but we are seeing for this year to start, because who knows what will happen in the next few years' time. Our upcoming events will, span various sectors, which doesn't include only the healthcare, but banking, insurance, financial, telecom, consumer goods, retail, media, supply chain, manufacturing, and I'm sure all the industries which I have not told are also going through the digital transformation and the technological advancement space. So stay connected with us about the tech news, upcoming events, registration details by visiting our website or following us on our social media channels. Your engagement is invaluable, so please continue to interact with and share our content within your network so that people who are not able to attend or who have not enriched for today's sessions, they can also join in for our future webinars, which we are planning to do. We extend our heartfelt thanks to InfoVision as well, who is our knowledge and innovation partner for this event. So to discover more about groundbreaking tech solutions which they are doing, please visit their website, which is infovision.com. Thank you once again for your participation and support. We look forward to hosting more insightful sessions in the near future as well. Wishing you a wonderful day, a productive week, and a transformative year ahead. Thank you.
Thank you, Nitin. Thank you, everyone.
Yeah, thank you.